This is Selma Schimmel in Chicago at the ASCO annual meeting for the group room where our discussions continue. And now we're joined by Dr. Supriya Mohile, who is a geriatric oncologist and associate professor in the Department of Medicine, Hematology, Oncology at the University of Rochester Medical Center. Welcome.
Thank you.
And I'm really thrilled that we're talking about the treatment of older cancer patients with dealing with advanced cancer and issues of balancing efficacy and toxicity. And as we were talking before we began our interview, there was a time where there was this common belief that if you're an older cancer patient, you're too frail and you can't handle aggressive therapy, and that's really not so.
Nope. So what we've learned, and I think with the help, I think people are recognizing with the population that's aging and us making as a medical community headways in treating cardiovascular disease and other life-limiting illnesses, that cancer really does strike very healthy older people. Our population's aging significantly. Currently 13% of our patients are over the age of 65, and this will increase to 25% by the year 2050. And so it's a large population of people. Underlying health status is very, very heterogeneous, and so you have really active older patients in their 80s who are living independently, playing golf, swimming, having very active lives, and without a lot of medical problems, and then they get cancer. And so it's really it has a big impact in that age group. And on the other hand, you have people who could be 20 years younger who have bad heart disease, bad lung disease, and those patients will have a lot more trouble with cancer. And so it's not the chronologic age, it's their underlying health status that makes more of a difference when we're assessing patients.
So talk us through that assessment, and also we'll talk about how we deal with patients that are older that do have other disease factors that may limit their ability to tolerate certain treatments.
So as a geriatric oncologist, we've tried to really integrate geriatrics and oncology a little bit more. In geriatrics, there's a compilation of tools called the Comprehensive Geriatric Assessment, which geriatricians use to really evaluate underlying health status, and it includes geriatric domains such as functional status, comorbidity, nutritional status, psychological status, cognitive status, social support. We know that each of those domains independently predicts morbidity and mortality in older patients, and so it makes sense that they would be predictive in older cancer patients too. And so we've sort of advocated that this should be incorporated into clinical care for older patients and help use that to guide decision making. You can risk stratify patients to what we call fit, very healthy patients, and then you have a middle group called vulnerable, and then the sicker group is called the frail patients using this assessment. And the data that we have right now in terms of treatment of older cancer patients are only the fit patients, because those are the only ones that get onto our clinical trials. And so we have this large group of vulnerable and frail patients who we have very limited data, so it's challenging trying to balance, as I said, treatment efficacy and side effects.
Is it also an issue dealing with patient perception, elderly patient perception, or I don't want to say elderly, older patient perception about treatments, because in their minds, being older, they may have ideas about cancer and older modalities of treatment?
Yes, there's definitely a cultural or sort of age-related difference. I think our older patients at the oldest old, so over the age of 80, I think defer to doctors a lot when making decisions. But you have this younger group of patients now, the baby boomers, just becoming 65, 70 now, who are very internet savvy. They advocate for themselves. And so I think those perceptions are actually going to change as our population ages and the people that are getting into the older age groups are very computer savvy. But I do think there's a difference there. I have this running joke that in geriatric oncology, I'm often telling doctors when I evaluate a patient, I have a consultative clinic at the University of Rochester where people can send me patients to get my opinion and do the geriatric assessment. So I have days where many of my opinions are, you should get treatment, you're healthy enough, you should get standard treatment, and I'm trying to convince the doctors and the patients that that's the case. So it's not always, oh, this older patient shouldn't get treatment or they're too sick. Many of it is, you're very healthy and your life expectancy now is is still 10 years. The life expectancy of a healthy 80-year-old patient is 10 years. And so those patients, their lives are going to be limited by their cancer, not by other problems, and they should get cancer treatment. And so I have a lot of discussions like that, too.
Do you ever have to deal with family members that don't want their, let's say, their parent or grandparent to go through treatment?
Yep. Family is very important in the care of an older patient with cancer. And I always get worried when I don't see family members in the room, and because then we're asking who's living in the area, what friends do you have to support. But daughters and daughter-in-laws, having them advocate for their family members is important. But a lot of it's this open discussion about health status and age, and how those things are important and influence what our recommendation is. So if I have an older patient who is very healthy, they may still die from their cancer and not from anything else. And so cancer still is going to be very life-limiting. And when you have that open discussion, I think people understand why the treatment's necessary. There is a whole degree of extra support and extra attention and extra care that needs to be provided to an older patient undergoing chemotherapy, for example, that we may not need to do for a younger patient that has more resilience.
Is dosing different in the older patient?
We need a lot more data. The way our clinical trials are structured is that we have recommended dosing, and that's what everyone starts out with who get onto the clinical trials. And that's challenging for an older patient, where you may want to test a dose first, a little bit lower, to assess tolerance, and then go up.
Right.
And our clinical trials aren't structured to allow that. There is data at this meeting that looks at who gets dose reductions up front, who gets changes in the regular schedule up front, and they tend to be our older, more frail patients. But there still may be efficacy to doing things that way. We just don't have the right kind of data.
Is there analysis looking at certain cancer types more than others in the older patients?
Yeah, I think what we like to see in the geriatric oncology community is that there's researchers in geriatric oncology that are advocating within certain disease specialties. And so, there's data in all disease specialties that have grown amazingly in the last 5 years. But I think breast and prostate cancer have data. There was a wonderful study called the Focus 2 trial that was published in Lancet Oncology, looking at how to give treatment for metastatic colon cancer in patients over the age of 70. Even at this meeting, we're seeing in all of the sessions, some data for patients age 70 and over, and so I think people are recognizing that this is necessary.
I find that someone who dedicates their life to helping geriatric patients, or the elderly in this case, that it takes a really special human being with
thank you.
compassion and empathy, and because there are a lot of challenges there.
There is, and what I find is it's incredibly rewarding, and I think the group of geriatric oncologists I work with around the country in the Cancer and Aging Research Group and elsewhere, they're very passionate about this. I think there's two biases. One is a bias to undertreat just based on age. So you have an 85-year-old, and we're not going to give you treatment because you're 85. And then there's a bias to overtreat because we don't have data for patients who may be too sick to handle the treatment. And so we really need to eliminate these biases, and we're very passionate about that. And as a community, advocate for that at meetings like ASCO.
Well, I'm really thrilled that we got to get this geriatric oncology update with you.
Thank you.
Thank you for what you do. Dr. Supriya Mohile, who is a geriatric oncologist, associate professor in the Department of Medicine, Hematology Oncology, University of Rochester Medical Center in New York State.
Correct.
Thank you.
Thank you
very much.